I joined iCare. My background was railways engineer in the railways for 20 years and in corporate for 7 years. And when I was going to be about 50, I joined Sightsavers. Zero knowledge or background on NGO working and much less on iCare, except that I was wearing a pair of. The reason I moved over was because some of you may know, most of you may know, I lost my left hand in 1966. But despite that, I did well for myself in both in the railways and in the corporate world. And I was working as vice president of Shalimar Paints, which was an MNC. And I was getting shortlisted to become the managing director. We were 3 of us who were shortlisted. My youngest daughter, who was about 12 or something at that time, asked me one day on the breakfast table, "Daddy, you've done well for yourself, but how about doing something for those who are less privileged than you?" So it struck me. I've been focusing so much on doing things for myself and my career that I never thought about it. I told her I would like to, but I don't know how. As it happened, a couple of days later, there was a newspaper advertisement asking for applicants for the field director for Sightsavers. At that time, it's called Royal Commonwealth Society for the Blind. And they had specified someone who is 30 to 40 years of age and an MBA. They said the job is to professionalize the way we work. So my daughter said, "Why don't you apply?" I said, "I don't qualify." He said, "You apply." I did. I wrote to them that you wanted someone like that. I am 50 years old and I'm not an MBA. I gave them my CV, which was pretty impressive in the corporate world. And I added a line, "I don't need this job, but I would love to do this job if I'm given a chance." I was interviewed, I was given the job. And Alan Johns was the director at that time, and Kevin Carey, a blind person, was the overseas director. They interviewed me and appointed me. And in 1999, March, appointed me. It took me some time to join. I joined in October. The first thing I knew was I knew nothing. I was an ignoramus. Zero was a good way to start learning, not doing. So it brought into me a lot of humility, because if I have to do as well as I've done in the corporate world, I have to learn what to do, how to do, etc. So I had a lot of gurus. In the INGO work, Mr. P.G. Michel, he was the regional representative of CBM at that time. What all I'm talking will be very different, dated, because I'm talking about 37, 80, 30, 36 years back situation, when there was no internet, there was no email, there was no mobile phone, there was conventional communication. You had to go through the operator trunk dialing to get any number. That was the type of situation. So P.G. Michel, I met him because I felt that I know from people who are in the field, and he was working for an INGO. We get on very well, and he gave me a mantra, which he got from Pastor Wiesinger, his executive director. He said, "Remember every day that I am not the donor. I am not the doer. The partner is the one who is doing the job. Donor is the one who is giving money to Sightsavers. I am an unnecessary, avoidable expense in between trying to link the two." So it was a tremendous mantra. Every day when I was to shave in the morning, I used to tell myself, I am not the donor, I am not the doer, because the environment You are treated as the donor by the partners, and you project yourself as your accomplishment, what the partner does when you go abroad to the board and report, etc. Next was Kevin Carey. He was my overseas director. He told me, Raju, if all your programs are running very well, then you are not running the right type of programs, because we are not in the business of doing what is possible. We are doing in the business of doing what is necessary. That means failure and lack of progress will be part of the program. So don't look for 100% success in your program. Look for 100% relevance in your programs. So that I kept. Then David Green of Seva Foundation, he told me that how to reduce the cost to the patient, the cost to the provider, and how do we bring it about by lowering the cost of supplies and lowering the cost of accessing services by the in those days and even now, cost of accessing services is equal to or sometimes much larger than the cost of the services themselves. So he's kept me focused on that aspect of patient's perspective on cost. And Suzan Gilbert, of course, my longtime friend and associate partner in various things, and we have traveled the globe together. And she taught me that we are dealing with peoples. We are not dealing with paper. We are not dealing with reports. We are not dealing with funding or anything extra. We are dealing with people. The patients are people, the providers are people, the partner is people, and of course the donor also is people. So there should be a people-oriented approach in everything we do. This is what I learned from them. This thing. Then for eye care, I had many gurus, starting with Dr. Venkateswamy, who took a lot of time in educating me in his own way. He used to, when I met him, he used to give me a Xerox of a paper. You tell his secretary and then give it to me. Nice article, read it. Then in the evening when I meet for the dinner, how did you like the article? You will ask me. You won't ask me, have you read it? Then I realized he expects me to read it. I thought he was giving me a leaflet to carry. So he made sure that I learned. Dr. Rao, who came with a vision of making eye care in India as good or even better than what was in USA. And he told me about a lot about quality and how you have to build in quality in the provision and compassion in the provision. From day one, LV Prasad had at least 50% of the services will be free of cost to the beneficiary. Then I had Dr. S.R.K. Malik, who was and Dr. Danda, a very senior ophthalmologist who pioneered eye banking and corneal grafting, Dr. Rajan Seth, etc., etc. And I had my own program manager, Godbole, who was a veteran and well used, but he was only doing eye camp management so far, if not whatever he thought he should be doing. And Khanawala, who was my administrative and finance director, he handled the office. The environment was, as I told you, pre-internet, pre-email. Looking at it, it will be very primitive era of this thing. Eye care also was pretty primitive. The national survey showed that India was doing 1.43 million surgeries a year. 98+% were ICCE with plus 10 glasses. 70% of them were done in surgical camps, not in campuses, in very suboptimal conditions. And there was seasonality. Eye work used to start, especially in northern India, after Dasara and hold up before Holi. Most of the equipment and major consumables were imported at that time. But luckily, I was at the cusp of a change which was augured at that time. Dan PCB, Danish government's prevention or control of blindness program, had just started. and a World Bank aided site program, and Lions site first was in the horizon. It was waiting to happen. While this was the environment and this was the performance, I found the INGOs and NGOs, CBM, Sightsavers, who were working there, and the partners themselves, they worked in isolation. There was mutual mistrust amongst each other. They were possessing the partners. For example, Sightsavers partners, we won't like a CBM person to visit them, or a CBM person to, or a partner to visit CBM, like that. So this was the thing. So my approach was from phase one was 1998 to 1990, 1.5 years. I just was spending time in learning what is happening, what needs to happen, how is it being done, what it should be, etc. Understanding what was happening. Luckily, I had no baggage, so I had to very discern the package I have to add to my this thing, and internalizing them, that this is what, as I told you, that I came into the job not for a job, but for giving back to society what I have received. So that was always in my mind. So I conceived of a purpose, and I presented a paper in the board meeting of 1999, 1990, in Hayward's Sightsavers headquarters. The title of the theme was "From Wherever Possible to Wherever Necessary." From whatever possible to whatever necessary. From however possible to however necessary. The first dealt with working in areas which were underserved or unserved. Second was in moving away from doing only cataract, and that to ICC cataract, to what all we need to do in providing eye care. And the third one was the quality. Whatever quality is done anywhere, and acceptable quality is the one which our partners should be performing, and we should help them do it, not to demand them do it. Then 1990 to 1997 was the implementing of these concepts. And I could realize, based on my experience, that a change doesn't take place overnight. I cannot legislate a change. I cannot order a change. I cannot say, if you do this, I'll come to you, otherwise I'll not do. No such thing at all. I have to make a transition, and I should help the partners make a transition. So first thing I did was I made the patient and the partner as the main drivers of programs, not the donor. At that time, it was the method of fundraising used to be in, you give us 10 pounds, we will give a cataract, and mail order and that type of thing. And people used to give 10 pounds, which was easy, and then you give them the unit cost cataract support was the mode by which we were supporting. And it was resulting in voluminous reports. In there used to be 3 forms. One, they sent a proposal called EC01, and then we give an approval called EC02, and then they will give a compliance called EC03, then we release the money to them, like that. And the EC03 used to come with 3 copies of the beneficiaries. And in the case of Aravind, which used to be, even at that time, a high volume worker, it used to be really bundles of paper which had to be sent by parcel from there to us. And GS told me they used to employ 2 typists to type the reports only. All that was wasted expenditure, and we were giving 100 rupees for a cataract surgery. And the cataract surgery in those days was you admit him the previous day, do the cataract surgery in ICCE, and keep him for a week, feed him, and give him bed. And in northern India, when I saw the beds, I recognized that they were doing it in a school building or a dharamshala or something, and doing some sort of a thing. And they had There is put on the floor and straw, and then on top of it a sheet, and people used to sleep there. So, and the one thing also I saw in surgical camps was, it was an eye-opener to me. Lions Club of Raniganj had an eye camp, and I used to spend 3 weeks out of a month out in the field seeing what's happening because I had to learn. So when I went to the Raniganj hospital camp, they had a hospital on one side of the road, and across the road there was a big Maidan, which was a football field or a community place or whatever. They put tents there, put a tent type theater, and put the people on the ground, and they were doing the surgery there. I saw the camp, and they took me for lunch to the hospital. The hospital was empty. The wards or theater, everything was empty. So I asked them, why are you doing a camp out in the Maidan and not in the hospital? They said, sir, if you do it in the hospital, you will not fund us. Because somehow or other, the funding by the INGOs used to be for camps done in a field. I said, it's absurd that you are supposed to do it in places where facility is not available that way, not when there is everything available. So all this gave me an idea. And whereas Aravind at that time was doing screening camps, not surgical camps, and bring the patient to the campus and then do surgery and then drop them back, keep them for a week and all that stuff. So first thing was to improve the camps themselves, surgical camps themselves. So Tanawala and I discussed, we ordered 20 sets of sterilizing equipment and supplied them, and surgical instruments and diagnostic instruments like ophthalmoscope, retinoscope, shared transcript, etc. Making them look at the eye a little more detail. The slit lamps were a rarity at the time, even in hospitals. So I said I should address this and make transition from surgical camps to screening camps and from camp to campus service. So that was, in all my discussions with partners, I used to discuss that, how we do it. Also, this type of funding made the program very non-sustainable or very fragile. Because if I fund, the camp will be done. If I don't fund, the camp will not be done. So I said that we can't have a thing which is fund-dependent programs. Eye care program should be able to run by themselves. Funding is an added breath of fresh air to them. That's all. It should be like that. Then seasonal to round-the-year care. I felt that I asked people, they said, no, in summer it's very hot. And in winter also, in December time, it's very cold, they used to close shop. So in one of my visits, I went to Modi Nagar to see the Gujaramal Modi Eye Hospital. And Mr. K.N. Modi, a senior industrialist, a very enlightened person, he was there. And while I was having lunch with him, I talked to him, why do you do only surgeries in summer? He said that because winter, nobody, in summer nobody will come, in winter people will come. I said, why don't you air condition your theater and air cool your wards and give a summer discount to people who will come to get surgery done, paying patients. And he did that to his credit. And he started, because I found in South India, seasonality wasn't that prevalent. And the other reasons were there for it, like festivals and all that, but seasonality. So I realized that I cannot dictate change. The only weapon I had was, I will not fund you. But I felt that since I am not the donor, I cannot say that thing. And since I am not the doer, I cannot tell him what to do. But certainly make him think. The first thing I thought was that we must try and move those ophthalmologists and hospital people to go and see how Aravind is dealing with patients, and I will give Prashad this patient. we evolved a program called the Vision Building Workshops, wherein first the doctors came and then a team came to orient them as to what is it they can do in the place. And always I used to talk about the national survey and the area, what is the problems, eye care problems there, and design the programs accordingly. So the partners who were interested in doing only eye camps, they dropped out. Partners who were interested in providing eye care around the year hung on. The only thing is they wanted to know how to do it. So the second thing I did was that how to involve the community. There were organizations in the community working on various things like afforestation or women empowerment or Kendo leaf in Orissa. So many things they were doing. So tell them that why don't you do rehabilitation of visually impaired, and we will fund you for that. So there was a 2-year module. You give them the equipment, the tricycles and all that. They do a door-to-door survey, link them to hospital, all that we did. So that they eye care become a part of their menu, and they were accepted figure in the community. The eye camp, most of the eye camps, I learned it in Assam and other places. The eye camps used to be organized by Lions and Rotarians. And Marwadis used to be the Lions and Rotarians. The Marwadis used to be considered as the exploiter by those areas, Naxalbari, those areas, etc. So when they tried to provide service, they felt that it was a soft touch to perennially keep them enslaved economically. So where community-based organizations, when they started providing eye care or getting involved in eye care, the community's acceptance was in a big way. Then the major problem I visualized was the silo type, isolated working of various organizations. So first I started networking with the other INGOs. PG Michel, at that time, Kalyan Gupta used to take care of OU programs. Hans Limberg of DAN-PCP, P.S. Ranganathan of Sightfirst, then Suzan of Suzan and David Green. So we said, well, we used to think that since the funding agency was funding money for cataract, we used to think the partners are cheating, getting double funding, because 100 rupees is not enough. So they will give the same list to CVM and get money, same list to OU and get money. So there used to be mistrust, and there used to be spying. We used to employ people to go and spy whether the camp took place, whether the number took place, etc. We used to cross-check whether they are getting money from somewhere else, etc. I said, I travel 3 weeks a month. I don't put a spy to my wife to see that she is okay with me. How can I spy with my partners? They should be told. The entire work should be built on trust. So we started a thing called joint or co-funding. And CBM, Michael and I started this in a big way with LBP, because at that time, MK Media, one of the medium which used to preserve cornea, used to be imported. And its shelf life was 3 months. And transit and custom clearance used to take more than 2 months. So when it came, it was already having a month or less than 1 month shelf life. So the way to solve the problem was not to work with the government to reduce the timing, to make it in India. And the International Eye Bank Association, Frederick was there, we discussed with him. So we said we'll fund it, 1/3 funding from Sightsavers, 1/3 funding from CBM, and we will make MK Media and LVP. That was the beginning, and that gave me a flavor that how this type of joint funding is very synergetic in making things happen. And that also gave me a impetus that why don't we make everything which is in ophthalmology in India? Dr. V actually raised that point to us when we were in Nairobi. He said, I feel guilty that I am giving one type of service to the paying patient, another type of service to the free patient, because the IOL used to cost $100 at that time, sometimes $120, $150, which was quite expensive. He said, if you can make IOL for $10, then we can give it to everybody. That we didn't know how to make it. Tulsi, myself, Suzan, David Green. Somehow he put that thing by 92, 93, IOL became a reality. ROL became a reality, started making IOLs. And from Sightsavers side, my concern was if we make IOLs available, I'm busting the time, Divya. Is it okay?
Yes, sir. Maybe another 2 minutes we can wrap.
No, give me 5 minutes at least.
Okay, sir.
So we thought, we said that we should give if you're making IOL easily available, you must give them the skill to use it. So Aravind Sightsavers microsurgery training was started later at LVP and other places. So that we were converting the ophthalmologists to do microsurgery first, then ECCE, then IOL insertion. So that put me to the idea that we must train everybody in all HR. So we started various type of training programs. And believe me, for none of this, the conventional fundraising was working. So whenever I used to go, I used to take the program concept, present it to corporate or other donors. There was state of Jersey in south of England, which was it was a tax haven, and they had a trust. I went and presented to them. For example, when NAM wanted to do indirect ophthalmoscopy, 30,000 pounds for training 30 people in a year. So they gave me that. Next year, I went to present them the report. They said, very good, and we'll give you another. I said, I want 60,000 pounds. They asked me why. Said that I want to give an indirect ophthalmoscope to them along with the certificate, because most of them cannot afford to buy a 1,000-pound indirect ophthalmoscope. They were all rural hospitals. They said, okay, we'll give you. So we shifted the donor profile from 10 pounds for a cataract surgery to a purpose specific items, etc. So, and then I built in a method of they're getting the tools of trade. If it does the microscopic training, he will get a microscope. If it does X number of IOLs, he will get a ES scan, etc., etc. And one item I added to the menu was the generator. Most of the places had equipment, but their equipment were idle because power was very erratic. So I got money for generator from a generator company in UK. While we did all this, I also found that Africa was sending its ophthalmologists to UK or Germany for training, and very few of them were coming back. So we opened the training programs in India, skill-based training programs to Africa. I invited Moses Chirambo and Anafal, who are leading the programs in Africa, to see, and then we started getting people there. Then product development, MK Media, or Lab, Low Vision Aids, etc., etc. And then once we started it, like I always give an example, the fog of a December morning. It's 100% you can't see anything, then 90% it's dark, and it's 80% dark, and then it becomes totally. So the taking off the new line of thinking was the problem. Once it did, everybody took off on this thing, and we had a public private partnership program with Dr. Bachani, who was a public health person in the World Bank project, and we as a consortium used to meet. The precursor was for the Vision 2020. Every month we used to meet somewhere or other and share what is being done what has been done and what needs to be done yet, and how we can do it and help each other in doing it, etc. The budgeting process I changed. The event-based budgeting is that you give me the list of cataract surgeries, I'll send you money multiple. I used to call this butler budgeting. I buy so many eggs, so many brinjal, so much of tomato, I give money that way. So I went about program-based funding. So I used to sit with the partners and discuss what needs to be done, what resources are required to do it, and what is the timeline, and what is the gap in the resources, how much of the gap they can bridge locally, and how much of the gap they expect Sightsavers to bring in. And write a memorandum of understanding with 3 years confirmed funding and 2 years extensible. So a 5-year profile. Most of the projects, we said that in 5 years, it should be able to realize what we initially tried to agree. We may do something else together. So my budgeting became a 3-year firm budget and 2-year provisional budget, which I used to present to annually to them, to my headquarters. And I used to put 20% of it as program fund unassigned. So my finance director asked me, why? I said that you want me to hold the projects and you want me to start new project. I don't know what projects will be in the horizon next year or year after. I must have a program fund to invest in it and do it. And it was agreed. And not only that, I made Sightsavers put a program fund in their own budgeting, keep unassigned money so that they can give. And that whatever we said we need, it became a target for the fundraiser to raise, and we used to help, etc. Doing all this, what was the outcome? 1990 to 97, we did that. And it was not mine. It was a collective thing, as I said, the INGOs and along with Sightsavers and with the government, we thought what we should do and how we should make things work, how it should become effective. In 1997, the total number of cataract surgeries being done in the country grew from 1.43 million to 7 million plus. What used to be 70% of it used to be done in camp, it became 100% was to be done in campus in the hospital conditions only, just straight away. Third was that almost all surgeries used to be ICCE with plus 10 glasses, which they used to break, or which were very low quality glasses used to be given. The person remained blind even after cataract removal. 100% became IOL. Not only that, the government passed a ruling that only IOL surgery should be performed under clinically contraindicated, and the government passed an order banning surgical camps. You should do surgery only in PHCs or places where proper theater and other facilities were available. Indigenous production of consumables became normal because IOL, sutures, medication, everything became available in India. As a good alternative, the people may still import or get imported equipment, but it's a good alternative. Similarly, indigenous manufacture of equipment, slit lamps, microscope, scan lab, laser, etc. came about. Indigenous training programs, a very number of training programs came in of skill, not only for ophthalmology, for the entire team down the line and different. This program managers course is one of the offshoots of that type of development in those things. And not only that, the training programs were accessed by the developing world. People from Nepal, Bangladesh, Far East, as well as Africa started accessing this. And most important thing was most eye care hospital became self-sustaining for running cost and growth. They were only asking for money only for adding on to the menu of services for whatever services they were doing. They were able to cross-subsidize between paying patients and free patients and also generate a surplus. So I think I'll stop there, having bust my time. But all this was in 1988 to 1997 period. 1997, October, I opted to retire. I'm a volunteer still from then now. Thank you very much for this opportunity.